Hello, everyone. My name is Andrzej Kwater. I'm an assistant professor at MD Anderson Cancer Center in Houston, Texas, as well as associate program director of the regional fellowship at MD Anderson. Today, I will be going over the second portion of our thoracic wall blocks that will be part of our regional anesthesia workshop at the TSA annual meeting in September. So in terms of me, I don't have any disclosures to report for this presentation. Again, to reiterate, recently in 2021, there was an international group of experts from our field in regional anesthesia. These individuals reached a consensus on standardizing nomenclature for various blocks, and here are some of the ones related to chest wall or thoracic wall blocks. On the right-hand side, you'll see the agreed nomenclature, and there's a big push for us to use this nomenclature, whether it be in journal articles or in the clinical setting, so that we can continue to establish consistency. You'll see we have the serratus anterior plane block, both superficial and deep, the parasternal intercostal plane block, both superficial and deep, and then the biggest change that you may see is the interpectoral plane block and pectoserratus plane block. These are now the new accepted terms for what previously was referred to as the PEX 1 and PEX 2 blocks. So you'll hear me using these new terms, or relatively new terms, in this presentation. So again, these are the blocks that I will be covering in this part of the lecture: the erector spinae plane block, the pectoserratus block, the interpectoral plane block, and both the superficial and deep parasternal intercostal plane blocks. So beginning with the erector spinae plane block. This is a block that many have heard of already. Many of you may already do these blocks at your respective institutions, but I wanted to just go over a few things from my end. So this block was first described by Mauricio Ferrero, Dr. Mauricio Ferrero. He initially described two case reports of patients with severe refractory neuropathic pain, one associated with metastatic disease to the ribs, the other from traumatic rib fractures. And he did these ESP, or erector spinae plane blocks, as an analgesic strategy for these patients, and had great results. The erector spinae plane block is named after the erector spinae muscle group. So there are three muscles actually part of this group: the iliocostalis, the longissimus muscle, and the spinalis muscle. You can see that in the picture on the top right there. And these muscles overlie the transverse process, which is our target for local anesthetic injection during this block. On the left-hand side, you can see an ultrasound image showing the transverse process being identified there, the erector spinae muscles over the top of it, and the trapezius and rhomboid muscles being more superficial to that. So the goal is to guide the needle towards that transverse process, contact the surface of the transverse process, and inject the local anesthetic in order to get cranial and caudal spread over several dermatomal levels. And you can see on the picture of the patient on the right side the extent to which the patient experienced adequate analgesia from the block itself. Expanding further, so the erector spinae plane block is a superficial parasternal, or paraspinal, interfascial plane block. As mentioned before, the goal is to inject the local anesthetic deep to the erector spinae muscles and over the transverse process. What results is a unilateral segmental analgesia, and studies have shown that several dermatomal levels are covered following a high volume injection, and I'll talk about this here in just a moment. The thoracic ESP block in particular, these ESP blocks can be done at the thoracic level or the lumbar level, but if we're looking just at the thoracic erector spinae plane blocks, these can be utilized for posterior analgesia, such as during spine surgery, as well as anterior lateral analgesia of the chest wall. So you can imagine the amount of indications that this block can be used for. You can do a single injection or thread a catheter after the initial injection, and this can be done on one side or both sides bilaterally if intended or needed. And the benefit of these erector spinae plane blocks is that there are no absolute contraindications of doing these blocks in patients with active coagulopathy or on systemic anticoagulation. Caution still needs to be taken in these scenarios, but unlike paravertebrals or neuraxial, there are not absolute contraindications to doing these blocks in these patients. However, if you have a patient who's thrombocytopenic or is on a heparin drip, for example, I would still exercise caution in doing these blocks, but they can be done, and case reports have shown that patients have undergone these blocks without any complications. And again, on the right side hand here, you see a nice ultrasound image. And the goal with these blocks is actually directing the needle right at the corner of that transverse process and injecting the local anesthetic and then pushing that erector spinae muscle group up and seeing a nice distribution of the local anesthetic in the cranial caudal direction. And you'll see this also when we scan at the meeting. The goal is to identify the transverse process and to not identify the ribs or the lamina. And there's a distinct ultrasound image of each of these structures that we're looking for as we're scanning in the sagittal orientation, left and right, away from midline, being able to identify these various structures and identify what's actually the transverse process, since you should not be visualizing pleura if you're identifying the transverse process. Again, here's an ultrasound image of a block that I did some months ago. This was a thoracic erector spinae plane block. On the left, identifying that surface anatomy of the transverse process, that nice squared off bony surface of the transverse process, the erector spinae muscle adhering to the top of it. And then on the image to the right, after injecting the local anesthetic, you can see that band of local anesthetic now lifting the erector spinae muscles up and spreading in the cranial and caudal direction. Here are a few studies that were done that again reinforce the utility of these blocks and the spread of local anesthetic in the cranial and caudal direction. Here you can see on the right-hand side of this cadaver with staining, there's one injection done at T5, and you can see the amount of spread in the cranial caudal direction. And on that right-hand side in the box in red, showing the extent of dermatomal levels that were covered. So anywhere from 9 to 14 dermatomal levels, I believe, is what they were able to depict in this cadaver study. And so this goes to show that with a single injection, high volume injection, you know, oftentimes 30 cc's of local anesthetic, you can get effective spread in both the cranial and caudal direction to cover several dermatomal levels. Here's MRI imaging showing the spread of injectate into the paravertebral space and towards the neuraxial space. And this is to explain the additional benefit that these erector spinae plane blocks have in terms of providing anterior lateral coverage. Many would think that just injecting posteriorly over the transverse process would just cover the posterior thoracic cavity, which would be useful for spine surgeries, but there have been many reports and studies showing that erector spinae plane blocks provide benefit for anterior lateral analgesia of the chest wall. And so the proposed theory is that that local anesthetic does spread into this paravertebral and neuraxial spaces in order to provide that coverage. Here's a quick summary of the erector spinae plane block. Indications, there are many for this block, and more reports come out of this block being used to provide analgesia for a variety of cases. But most often we'll see it being used for spine cases, breast surgery, thoracic surgery, trauma, including rib fractures, and those sort of scenarios. A linear or curved linear transducer can be used for these blocks, depending the amount of tissue that you have to visualize before you can identify the transverse processes. And an in-plane and out-of-plane technique can be used. Most often, you'll find people using the in-plane technique, but out-of-plane is acceptable as well, especially as you become more comfortable with these blocks. Now, this is a volume block, so injecting up to 30 cc's is not unusual, and that allows that craniocaudal spread of the local anesthetic. And again, just a few points. When we're going in with that needle in plane, we want to target the corner of the transverse process, where we can lift the erector spinae muscle off of the transverse process using hydrodissection initially, but then injecting the local anesthetic afterwards once we confirm placement. And we do have to be careful. There's always a potential risk of that needle advancing too far and potentially resulting in a pneumothorax. That's why identifying the correct structures, staying away from pleura, and always visualizing your needle is very, very important. So now moving on to the anterior lateral chest wall. So we're going to be first talking about the interpectoral plane block. So this was initially termed the PEX block or PEX 1 block. So this was first described by Blanco in 2011. This block was utilized for patients undergoing breast surgery, and patients experience very effective analgesia following these blocks. And so this is how this got adopted as a technique for providing analgesia of the chest wall. So this is a fascial plane block with injection of the local anesthetic in the fascial plane between the pec major and pec minor, blocking both the medial and lateral pectoral nerves. So Blanco described that these blocks were especially effective for patients receiving tissue expanders or subpectoral prosthesis. And he found great results for that patient population. You can see an ultrasound image from this article showing that local anesthetic spread between the pec major and pec minor. So going further, again, this is the interpectoral plane block, formerly referred to as the PEX block or PEX 1 block. So we're injecting local anesthetic into the fascial plane between the pectoralis major and pectoralis minor muscle groups. So in order to do this block, the ultrasound probe is oriented in the sagittal plane, just medial to the coracoid process. This is a similar area to where you would identify the infraclavicular brachial plexus nerve block. So you can identify the relevant vasculature in that area. And you can also visualize the pectoral branch of the thoracoacromial artery that lies in that fascial plane between pec major and pec minor. So once you've identified that artery, the pectoral nerves will be in that same plane. And so injecting local anesthetic in that plane will block both the lateral and medial pectoral nerves. Now, these nerves originate from the brachial plexus, and they innervate both the pectoralis major and minor muscles. And as I mentioned before, this block is great for patients that are getting tissue expanders or having subpectoral implants or prosthesis placed. Here's a quick summary of the interpectoral plane block. So as I mentioned, these most commonly are used for breast surgery, although there are other indications. Most of the time we're using a linear transducer, injecting in plane, although out of plane is acceptable as well. And the dose of local anesthetic or the volume that we inject is usually 10 to 20 cc's. That provides enough spread into that fascial plane to contact those nerves. And again, identifying the relevant vascular structures nearby. If there's ribs, pleura anywhere in the vicinity, identifying where those are and making sure that you have correct needle identification as well to avoid any potential risks or complications. Moving on to the pectoserratus plane block. This is again new terminology or newer terminology that we're using. So previously this was referring to the PEX 2 block, or at least a component of the PEX 2 block. So Blanco, the next year after first describing the PEX block or PEX 1 block, he described this modification where you inject local anesthetic below the pec minor muscle, but above the serratus anterior muscle group. And this allows spread of local anesthetic into the axilla to provide better sensory analgesia and cover the lateral cutaneous branches of the intercostal nerves of T2 to T6. So here he demonstrated dye on X-ray spreading into that axilla and providing additional analgesia. So this was a modification on the original PEX block, and the combination of the original PEX block plus this additional injection was referred to as the PEX2 block. But now we're referring to the single injection in that fascial plane under pec minor and above the serratus anterior muscle in that fascial plane as just the pectoserratus plane block. So here's some images, some diagrams clarifying the benefit of this initial injection into this pectoserratus plane. So you can see on the top right-hand corner, you're going to anesthetize the lateral cutaneous branches of the intercostal nerves. You will also get spread and block the long thoracic nerve, which I'll discuss whether that's a good thing or not in certain cases. And on the left here, you have the intricate innervation of the breast and axilla itself. So you can see just blocking the medial and lateral pectoral nerves there in black are going to give you coverage of the cutaneous surface of the breast and axilla. So adding in this additional pectoserratus block does provide great analgesia of the anterior lateral chest wall and in the axilla. So here's a little more about the pectoserratus plane block. Again, we talked about the nomenclature. We're going to refer to it as the pectoserratus plane block. Again, injection deep to the pectoralis minor muscle and superficial to the serratus anterior muscle. And this injection follows along the same plane as the serratus anterior plane block. So you'll see a lot of individuals pretty much refer to these as the same block in itself, since the local anesthetic is spreading along the same plane. The serratus anterior muscle group does start coming into the image, coming over the ribs as you scan more posteriorly. So this injection will spread into that plane. So that's why the endpoint for the injection is very similar to a serratus anterior plane block. As mentioned before, this block is targeting the lateral cutaneous branches of the T2 to T6 intercostal nerves, providing additional axillary coverage. And the long thoracic nerve does get blocked with this fascial plane block. So that's an important point and something that needs to be discussed with the surgeons, because there is concern that by blocking this long thoracic nerve, which supplies the serratus anterior muscle, oftentimes surgeons would like to identify this nerve when doing an axillary dissection. And so if there's no response from the nerve since it was blocked with this fascial plane block, there's concern for risk of nerve trauma during axillary dissection, which could lead to what we refer to as wing scapula if that long thoracic nerve is damaged. So always a good idea to talk with your surgeons prior to doing this block and making sure that they understand what nerves will be blocked with this specific block, so there's a good understanding that we're not putting the patient at any additional risk during surgery. Again, a summary of the pectoserratus plane block, a variety of indications: breast, thoracic, cardiac surgery. Most of the time we're doing this block with a linear transducer. In plane or out of plane can be used. The injection is about 20 cc's of local anesthetic. And again, visualizing your needle throughout to avoid contacting pleura if that is somewhere in the vicinity, or at least identifying pleura so that you're not anywhere in the vicinity with your injection. Moving on to the peristernal intercostal plane block. So this was described by Dr. Alfaro de la Torre. This was utilized as a better alternative to intercostal nerve blocks to provide more sufficient breast analgesia for breast cases. As you can see from this image, the ultrasound probe is placed in the sagittal orientation, just lateral to the sternum, identifying the ribs or costal cartilage as it joins the sternum, and injecting in the fascial plane under the pec major muscle and above the intercostal muscle in that fascial plane. And that fascial plane should contact the junction of the ribs. So you should be able to see that local anesthetic spread effectively in that fascial plane. So there is both a superficial and deep approach to these blocks. The superficial approach, which tends to be more common and many would argue is safer overall, is injecting in the fascial plane between the pectoralis major and intercostal muscles. So you can see that in the depiction on the top right-hand corner. Once you inject that local anesthetic, you'll see the spread along that fascial plane. And most often, individuals will have their needle contact that costal cartilage or that rib as it's joining along on the sternum, and use that bony landmark as an endpoint for the needle itself to increase the safety profile of this block. The deep approach to this block is an injection between the intercostal muscle and the transversus thoracic muscle, or TTM, as you see labeled in that picture there. However, the internal thoracic vein and artery do travel in this plane, and so making sure you can identify those structures prior to doing this block will avoid any accidental vascular puncture. So that's why many will argue that the superficial approach to this block has a higher safety profile, and clinically both have been shown to be equally effective. This block is targeting the anterior cutaneous branches of the T2 to T6 intercostal nerves and is utilized in many clinical scenarios, such as during cardiac surgery, if there's sternotomy, for medial chest wall coverage during breast surgery, for medial components of rib fractures, and for sternal fractures. So again, here's some additional images, ultrasound images and diagrams showing on the top there the superficial approach to the parasternal intercostal plane block, as well as the deep approach there. And again, we're targeting the anterior cutaneous nerves, anterior cutaneous branches of the intercostal nerves. So just a quick summary. I talked about the indications for this block. Most of the time we're using a linear transducer going in plane or out of plane. Most people will go in plane with their needle. You only really need 10 to 20 cc's maximum, depending on the efficacy of your injection. And you do want to aim for that junction of the fascial plane onto the costal cartilage or rib, and identify any surrounding vascular structures so that you know where you're injecting. So that summarizes this second portion of the thoracic wall blocks that we'll be going over during the regional workshop. So just to kind of go through the conclusions of our lecture. So it's important to understand the relevant anatomy, the corresponding innervation, and the sites of various surgical interventions that patients undergo. This will allow you to best target the areas where you want to provide the most effective analgesia and choose the block that is most appropriate for these scenarios. There are a variety of regional anesthesia interventions that we've gone over. There's even more, but these are the most common ones that are utilized, and they can provide effective perioperative analgesia for the thoracic and chest wall. So historically, the focus for thoracic wall analgesia was utilizing thoracic epidurals, paravertebral blocks, and intercostal nerve blocks. But now that we have a variety of fascial plane blocks, these have shown to be safe and effective alternatives to provide effective analgesia for our patients. And all of these regional anesthetic interventions have varying levels of associated risks and/or complications. So understanding your patient population as well as the associated risk with each of these interventions will allow you to choose what's the best intervention for your patient in that specific scenario. And again, summarizing, these thoracic wall blocks do provide effective analgesia and are most commonly used for breast surgery, thoracic surgery, cardiac surgery, also seen in trauma with various fractures, and the ability to provide analgesia, whether for operative scenarios or non-operative treatment of fractures. These are some references that were utilized in making this lecture. And again, this is our intro page. My email is at the bottom. Feel free to reach out to me if you have any additional questions prior to our regional anesthesia workshop in September. Really looking forward to meeting everyone and scanning to identify all of these blocks and just working with you all in this workshop. Lots of great information to go over, and looking forward to seeing everyone. Thank you again for your time and for listening, and feel free to reach out if you have any questions. Thank you.